Hello, everybody. Good afternoon.
Hello, good afternoon.
Today's subject will be fairly easy, just as the last one. As a matter of fact, this is a complementary subject on the last one. For further readings, I recommend that you read Schwartz, the 10th edition, just a chapter about metabolic response to injury. If you want to further investigate or do your research. This is very simple. This is a complementary subject on the last one, and this occurs mainly in every patient who experienced some sort of trauma or any patient that has been involved in surgery. So, okay, let's get going. Can you all see the presentation, sorry?
Yes, we can see it.
All right. So let's get going. As I explained, after a major trauma, there are a series of events that take place, physiologically speaking, the release of hormones and metabolic or inflammatory process starts going on. And the sympathetic system has to be involved in order to keep the cardiac output and, a sort of response in every other system in order to keep the body from harming itself further on. So it is the stimulus is an accident or a trauma or a surgery. So the whole body, the whole organism acts together in order to return to normal homeostasis. And therefore, we have to be aware of it and start resuscitation to act properly, to diminish damage during surgery, and to try to help our patients to return to normal as possible, because this is some quite paradox. The body releases chemical substances that will mediate inflammation per se. And this inflammation itself will cause harm to every tissue in the body. But these substances also try to diminish or to stop the harm to keep on going. So in the first, as an acute response, it'll be okay. These substances are the ones that will keep us alive. But if this kind of response still or continues, it will ensure that we fall into a state of auto-cannibalism. That means we start literally eating ourselves. So as a consequence, the metabolic response to injury will ensure, and we have to know this in advance so we can ensure an optimal response to that. So there are components, there are the physiological consequences, the metabolic manifestations. Of course, there will be reflected as a clinical manifestation and laboratory changes. The physiological changes are just about the same that we saw during the shock. the cardiac output needs to be increased because the metabolic rate, the basal metabolic rate will be increased as well. So every other organ and system needs to compensate this increase. Therefore, by increasing the cardiac output, we have to increase ventilation, and we have to increase every membrane transport that also needs energy. And because it needs energy, there may be a bit of a weight loss depending on the trauma, depending on the injury, depending on the time that we are exposed to that injury. And of course, if there's some talking about surgery, we will be talking about wound healing as well. And the metabolic changes, as I said earlier, we increased our basal metabolic rate. It will be increased, and therefore every metabolic pathway will be directed to keep glucose running in our system. But the thing here is that, as you can recall, the metabolic pathways, they will all take place, and they will not take as a substrate only carbohydrates. They will take every other substrate in order to keep glucose running on the bloodstream. And that means gluconeogenesis will be activated. Therefore, we will use every lipid cell to oxidize and form ketone bodies, and also we will make use of proteins. This is good, but not too good. This is good just in the first hours of it, but if this situation, this combined situation, such as the physiological and the metabolic conditions, can you imagine having both of them coexisting together for days, for weeks, or for months? Then this individual will not survive, because we cannot have this going for very much longer. Now, as a response to this, how are we going to find our patients? Well, if they have the cardiac output increased and their metabolic rate increased and all of their metabolic pathways directed to generate glucose in the bloodstream, we may find a bit of a fever if we're talking just about trauma or surgery. But if we're talking about a sepsis, shock, then we have a source of fever, right? We're going to have tachycardia, tachypnea, and we're going to have anorexia. And on our laboratory, we're going to find either high white blood cells or low white blood cells. Of course, we're going to find hyperglycemia, and we're going to have some acute reactant phase of protein C activated. And if these physiological changes continue, we're going to find ourselves a renal dysfunction. I'm going to make a stop in here about renal dysfunction. You can find it as pre-renal, okay, renal itself, and post-renal. An example of pre-renal is before entering the kidney, and the most common cause of pre-renal dysfunction is hypovolemic. As you can recall, about 25% of the cardiac output goes to the kidneys. So if, let's assume that we have a hypovolemic shock, either hemorrhage or non-hemorrhage, so we don't have very much volume to perfuse the kidney. Therefore, the kidney will start failing, and as a result, we call this a pre-renal dysfunction. Now, of course, how do we manage this? by infusing volume, right? So if you see a patient that has been in an accident or a car crash and you find them to have a creatinine above 1, let's say if he has 2.5, you're saying, okay, this individual has an acute kidney failure, and the cause of it, you need to classify that accordingly. It is pre-renal. Therefore, what I need to do in order to reestablish the kidney failure is to hydrate your patient, and therefore the kidney will improve itself. Was this clear?
Yes.
Sorry, wait a bit. Sorry, I have to go away for a minute. But is this clear? So you have to watch out for kidney failure, and on the setting of trauma, the common cause is pre-renal due to hypovolemic shock. Now, renal, it has to be something intrinsic about the kidney, such as these diseases of the glomeruli, such as having autoantibodies directed to the membrane of the glomeruli. That's renal. And post-renal is after the blood has entered the glomeruli, there is something obstructing. The most common cause of post-renal kidney failure are stones or infections. So that's after the filtration process has been taken, and the correction is accordingly. So, depending on the injury, on the intents of the injury, of the time of the injury, the response will act accordingly. This is to say, if you have a minor trauma, such as, okay, you fell out of the stairs, about 4 to 5 stairs, and you just you hit your head and you were bleeding, and you hit your arms and your legs and you're bruised all over, you will be experiencing a response to trauma, a big response to trauma, and you will recover very quickly, right? But let's say if you didn't fall out 4 to 5 stairs, you fell out of a building about, I don't know, let's say 5 meters high, and you broke your hip and you broke your femur, and you have a head trauma, an epidural hematoma, and you have 3 broken ribs. You see what I'm getting at? So this is a major trauma. The intents of trauma was longer, not the duration, but the injury itself was greater. Therefore, your metabolic response will act greater, in a greater proportion, to try to stop this, okay? And it will last longer, of course, and your recovery period will get there further on. This is quite, it makes sense, right? It just makes some sort of logic, right? So if you have an injury, you have to support all your vital organs. It doesn't, think about the size of the injury and the time you have been injured. Think about all those people, for example, that have been on an earthquake. They get trapped, and their legs had been crushed, and none of them will find them in the first hours. They took days for them to be found. So you have both. You have the intents of the injury great enough to cause a great serious response, metabolic response to it, and you have a great duration. So the support to vital organs needs to take place. And well, your response is going to be great enough to sustain your vital organs and keep you alive. Now, the mediators of this response are hormones mainly, and cytokines. And we have, therefore, everybody will join this party, all right? So you're going to release growth hormone in order to keep glucose going in the bloodstream. You're going to release ACTH in order to release cortisol. We're going to release adrenaline because we need to keep our blood pressure high enough to keep our cardiac output. We need to release some sort of cytokines such as interleukins. You recall this, the 1, the 6, and these two will cause a fever. They will cause the temperature to rise, and the necrosis factor that will cause catabolism, especially in the skeletal muscle, and all of the metabolic pathways will be turned on. You mean your Krebs cycle, your beta oxidation, all of them will have glucose running because they need to keep the vital organs alive. Which are vital organs? We need the heart to keep pumping on, and we need our brain to keep functioning, and we need the lungs, and we need
We can't hear you.
I am so sorry I got disconnected. It never happened before, but it turns out to be that I'm at school, and the broadband in the school, it just sucks. I'm sorry, I'm back again. The broadband got disconnected. I'm back again. So they classify these between two phases. The acute phase, where everything takes place, and these changes are somehow good for the short-term survival. But if we have something going on that increases the duration of these changes, then we switch to the chronic phase. And in the chronic phase, then we start wasting ourselves and eating ourselves. And we fall into an eternal catabolic phase, which is neither good nor beneficial to survival. Now, in the acute phase, they provide the essential substrates. Therefore, we need mainly energy, and all of the catabolic ways, they start to take place. They do this in order to save us. So we put in the balance, is it helpful? Is it harmful? Yes, it is a bit harmful because we're increasing tons of substances that will promote inflammation. But at the same time, we're stopping the injury. So in short term, we say, okay, it is good, but not anymore.
I have a question.
Yes?
When there's trauma and there's hyperglycemia, why is there inhibition in the sensibility to insulin? That doesn't make sense to me. If the body is in a emergency state, wouldn't it need, like the cells, wouldn't they need to use that glucose? And it is released, but it can't be absorbed. So what's the reason for that?
Yes, but that's a very good question, Julie. There's some sort of insulin resistance, because we don't want our muscles to take the glucose we are releasing. Am I making myself clear? We have to, how do you say the word?
Prioritize?
We need to sacrifice something, okay? So if you have, the glucose is like the gold that we're releasing into the bloodstream. And in such circumstances as this is an emergency state. So in an emergency state, you have to keep your vital organs alive. And you're going to sacrifice those that you don't need to live on. Am I making myself clear? Therefore, for instance, in the muscle, in the skeletal muscle, or in the intestines, you don't need your glucose right now, okay? The stomach, you can live not without the whole stomach, but it is not an emergency state right now. What you need to live, you need your brain, your heart, your liver, and your kidneys. That's where all the glucose is going to go. You're going to shut down every other organ and every other system, such as the skeletal system. You're going to shut it down. And if the situation gets worse, then you're going to sacrifice something else, like the kidneys, for instance. So this is some sort of emergency state where you need to channel all your resources to the very vital organs. That's why resistance to insulin develops. Was this clear?
Yes. The only question I have is, so insensibility to insulin just happens in the muscle or in organs that are not vital, or also in the brain, for example?
No, not the brain.
Okay,
the brain
so it
needs
only
to stay alive.
in the organs that are not necessary for survival.
Yes.
Okay, thank you.
And also, just as the metabolic waste, for instance, in the cardiovascular system, what happens is there's a generalized vasoconstriction. And this makes sure that your vital organs are getting enough bloodstream to survive. Therefore, they're going to shut down every other capillaries that are not needed in an emergency state, such as the limbs. That's why a person that has been on trauma, they are cold. Their hand and feet, they're cold because the vascular system is making that sacrifice. We don't need blood on our fingers nor in our toes, but we need that blood especially and mainly in the brain, in the heart, and on our kidneys and on our liver, right? So we're keeping that blood in those vessels, and we're going to sacrifice any other vessels that don't. They will not meet our needs in order to keep the emergency state, to get out of the emergency state. Was this clear?
Yeah, it's very clear. Thank you.
Okay, I have a question here. They say, what is the function of the endothelin-1 in cytokine in trauma? That's what I was just saying about. the whole system is going to release substances that will respond to an emergency state. And what is the emergency state? Keep glucose to vital organs and keep perfusion to vital organs. So the endothelin, its main role is to cause vasoconstriction on the parts that I don't need them right now on an emergency state. And what parts are those? Essentially the limbs. I don't need on my arms nor on my legs. I need my blood somewhere else. So the physiological response to this, of course, is, can you move? No, you cannot move. Are you hungry? No, you're not going to be hungry because you're eating yourself. Your entire system is releasing substances to keep you out of this emergency state, to keep you alive. And we have these phases. So once the injury begins, we have the shock that it is within the first hours, and we call this the F phase. Now we have the other phase, which is the flow phase, which is the catabolism, that we are trying to get out of this phase and return to normal. And once we are out of injury and out of danger, then we are returning back to normal physiology, and this is the recovery, and this lasts for weeks. And on the recovery state, then we are constructing back again everything. That means then our anabolic pathways will take place. And how long is this going to take? Well, it depends mainly on the injury. All right? Let's say you have, let's set an example. You have a pneumonia, all right? A healthy individual that is, well, he was under eating and he got pneumonia in a hospital. So he falls into a sepsis, not septic shock, but sepsis. So the injury is the bacteria that caused him the pneumonia, right? So you as a physician realize that he has pneumonia and start him on antibiotics and start him on IV solution and make sure that that he's responding well to the antibiotic you just given him. So the F phase will release cortisol, growth hormone, vasopressin, endothelin, and once the antibiotic took place and killed the bacteria that he had, then there's the flow phase. Now he's starting to get out of the injury, all right? So he has no fever, his white blood cells start dropping, he starts feeling better, he's not coughing anymore, he's breathing properly. So the antibiotic made his work, all right? Now he doesn't have any bacteria, his chest x-ray looks very clear, he's breathing normally. Now he gets to go home. Now he's in the recovery phase, and he will feel weak, of course, because he had been through the catabolic phase, all right? Then he will feel tired, all right? He lost weight during his hospital stay, and you have to tell him that he's going to recover during the next few weeks, all right? You're going to give him a diet which is high or rich in proteins because he's going to fall into the anabolic state. And the happy story. Now, there's another one. Let's say the same example, but it turns out to be that this man is also diabetic, non-controlled, he's hypertensive, and he just had a heart attack in the last year, all right? And he is, let's say, 78 years old. And the bacteria that he has caught, it was during a hospital stay, and it turns out to be that it's a Pseudomonas. Can you picture this? Now, the injury is not the same, right? Because we're not talking about the same patient, and we're not talking about the same bacteria. All right? So it turns out to be that his shock phase, it lasted very much longer than the first case. All right? So you had to intubate him, you have to make sputum cultures to see the sensibility of the antibiotics of the Pseudomonas, and it turns out to be that it is resistant to everything, plus he's diabetic. That means that his immune system is somehow shut off. So his flow phase starts not days but weeks, right? You even had to put him into the intensive care unit, and he lost about 8 to 10 kilograms in the month that he was there. Then all right, he responded well to the antibiotics. His chest X-ray, it started to look a bit better. His glucose is now within the normal range. And after 4 weeks of being hospitalized in the intensive care unit, you finally release him home. Therefore, this patient will need lots of therapy because he wasted every muscle he had. We're going to see further on. And the recovery is going to take even longer than in the first case. All right? You see what I'm getting at? It's pretty logical, right? So, the F phase, you're going to have if it's untreated, your temperature is going to decrease. Of course, your oxygen consumption is going to decrease. You're going to fall into lactic acidosis. You're going to have hyperglycemia because of the gluconeogenesis. And you're going to have immune activation. In the flow phase, which is the catabolic phase, you're going to see all of the other changes. Still hyperglycemia because of the proteolysis and lipolysis. You're going to have immunosuppression because all of the interleukins that have been released. You're going to see increase in your oxygen consumption, and we're going to see this further ahead. You're going to have your nitrogen balance, you're going to have it negative. And we're talking about muscle wasting. Now, in the anabolic phase, everything it comes back to normal. You have your positive nitrogen balance, and your hormones levels return to normal range. The F phase may last. To be beneficial, it has to be in short terms. That means 24 to 48 hours. And then you're going to move on to the flow phase. Now, the flow phase may last to several weeks. It depends on the injury itself. But this phase, careful, because it involves a lot of mobilization of energy stores to repair and recovery. Keep this in mind about energy, mobilize energy, because we're mobilizing mainly skeletal muscle. Now, the key catabolic elements of the flow phase is the increased metabolism. We're going to have to eat our muscles in order to gain glucose. And the insulin resistance that I was just telling you about, and Julie was asking before. Now, in the major trauma, this includes that we're going to have increased sympathetic activity, increased protein turnover, and we're going to have some circulation abnormalities because we have the increased sympathetic activity in order to keep blood flow where I need it the most. Okay. I told you this. In the flow state, where we are in a catabolic phase, we are still needing glucose in order to repair and stop the damage. So we're making use of lipids, but also we're making use of the muscle, of amino acids. And this, in turn, will increase our patient to become non-mobile. Okay? Careful with this. It will cause immobility, but immobility in elderly can be fatal. So take a look at this. All right. We have some clinical measures as a reflection of the catabolic state per se, and these are positive reactants and negative reactants. That means positive, it means that the concentration means that my response is great enough, right? So increases in plasma, that means that I have a positive response. And negative reactants, that means that if my albumin starts decreasing, then the condition is getting worse, such as protein, C-reactive protein. This is a very acute reactant, and it will increase in trauma, in infection, and in inflammation. But if my albumin, which is my predictor of my nutrition state, my nutritional state, if my albumin starts decreasing, that means that my condition is getting worse. So keep in mind these two, and you can measure them to see if your patient is how your patient is reacting to the metabolic response to trauma. There's the insulin resistance that we already talked about. And in skeletal muscle, okay, watch this. We have, for every protein that we have in our muscles, there is some degree of net weight of nitrogen. As you can recall the biochemical structure of a protein, you can recall that it has nitrogen in it, okay? Don't look at the numbers. Don't look at the numbers. The numbers are just to express something. So, if I'm starting to breaking down my proteins in my skeletal muscle, I will be releasing nitrogen into the urine. Is that clear? So, this nitrogen in my urine, it is a so-called urea, all right? So if I normally ingest about 70 to 100 grams of protein every day, I will release some nitrogen between 14 grams a day, and that's normal. That's having a normal nitrogen balance, all right? But if I fall into trauma and metabolic response starts in a catabolic phase, and I'm starting to eat myself the skeletal muscle, then this urea is going to increase. Therefore, I'm gonna have a positive nitrogen balance. I mean negative nitrogen balance. That means I'm losing more nitrogen than the one that I'm ingesting. Why? Number one, I'm not ingesting anything. Number two, I'm breaking all of my proteins down in order to get glucose, and that is going to result in a negative nitrogen balance, which can be measured in the nitrogen in the urine. Or, yes, that's the boom. That's the boom. So if you measure the bone and you find it to be increased, then the thought has to follow this way. Okay, I'm having too much nitrogen, so I have a negative balance because my patient is in the catabolic state, all right, making his gluconeogenesis out of skeletal muscle. All right? Is this thought chain clear enough?
Yes, it is. Thank you.
So,
Yes, sir.
this situation has to have a limit because you cannot eat every muscle of your body. All right? If you're in a fasting state, you're going to eat yourself, and you're going to have a negative nitrogen balance. But once the body reaches between 30 to 40% of the total protein mass, which is almost half of what you have, survival is not possible up to this point. Okay? So you have to make sure this situation doesn't go on very much further on. You have to stop it immediately and make every effort to make the flow state as short as possible. For example, between 1 to 10 days, I think I said it in an earlier session. You can have a patient on a fasting state 1 to 10 days at the most. Okay? You already know that that patient that you have on a fasting state, for whatever the cause, is increasing his nitrogen excretion, all right? So you're losing. Between these days, the total amount of proteins that he has lost ranges between 15 to 20%. Can you believe this? This is incredible. So between these 15 and 20%, you have to stop this right away. So by day 10 at the most, you have to start some nutrition in this patient. All right? Either having an oral diet or enteral diet or parenteral nutrition. All right? I always say by day 7, you have to start thinking about the patient's nutrition. If you do not decide for whatever the reason, then you have until day number 10 on a fasting state to think what's going to be the next route to start nutrition on. That's why people that have been in the intensive care unit or have been on a major trauma, they have to go to physical therapy because they lost a lot of weight and they lost skeletal muscle. So the strength that they had before the incident is not the same, and you need to help them recover afterwards. Okay, are there any questions so far? Now, there are ways to prevent this. I have a question. Okay, yes?
Sorry, I have a question about when do you have a positive balance of nitrogen? Would it be when
you start?
Sorry. Sorry.
Yes, I can hear you. Yes.
So if you are in a normal state and you're eating well, then you would have a positive balance. You're not excreting as much nitrogen.
That's right. Either how, not just eating well, but let's assume that you are on a diet where you have to consume an enormous amount of protein, like eggs, meat, and so forth. And so you're consuming a lot more than normal, and you're just excreting those 14 grams per day. So you make yourself to stay on a positive nitrogen balance.
Okay, thank you. So in what stage do you have positive balance of nitrogen? Is it in the flow one or in the?
No, you don't have.
Ever?
In any phase, you cause it. For instance, in these people that you already know they've been on a flow state and they switch to the recovery phase, you already know that these people lost some percentage of the skeletal muscle, right?
Yes.
So one way to approach these and to overcome these nitrogen loss is that you're starting on a high protein diet. That's the point where you cause them to have a positive nitrogen balance.
Okay, thank you.
You're welcome. Yes?
So, what is the normal range of nitrogen in urine?
The normal range? The normal range, it does not go greater than 20-25 milligrams per deciliter. You measure it in a blood sample.
And that's the normal one, or it's something different?
No, sorry, say that again?
That 20 grams, I think. What's the unit of nitrogen? Grams or?
Milligrams per, I'm going to write it down.
Okay, thank you.
The normal amount of urea, it is measured in the serum, right? And it ranges between 7 to 20. At the greatest, you can say 25 milligrams per deciliter. That means you have a normal nitrogen balance. But if you increase this, you will have a negative nitrogen balance. So, what are you going to try to avoid in order to shorten the flow state and the catabolic state? Well, if your patient is bleeding, stop the bleeding. If your patient is hypothermic, we'll try to cover him up and try to increase his temperature. And otherwise, if he has a fever, well, lower his fever. If you have, of course, you're going to have some tissue edema, we'll try to resolve it as quickly as possible. Or if your patient is losing perfusion, where you have to manage this, of course. If your patient is in starvation, I told you earlier, you have until day number 7 or 10 at the most to start thinking about his nutrition. It is urgent. And of course, think about the immobility that you have your patient. The longer that your patient remains without being mobile, the longer or the greater the skeletal muscle he will lose. Get me? That's why in the elderly people, that they don't move, that they don't walk, that they just stay in bed, the longer those people and those patients stay without moving, the greater the nitrogen loss will be. So keep moving. We've talked about this earlier, about the volume loss. You infuse crystalloids. Careful about the administration of colloids. As a matter of fact, they're forbidden right now. There has been no data that shows any benefits or any benefits with it. And careful about patients with hypothermia, because if they fall into hypothermia, they will fall rapidly into acidosis and cardiac complications and death eventually. That's why when you see on a trauma patient that they cover it with these silver sheets, have you seen it?
Yes.
On a movie or something? They cover it to avoid hypothermia, because hypothermia and acidosis is one of the things that cause death. The edema will result.
What is RT?
Yes.
Sorry. What is RT?
Yes, because the balance of the acid base, it is under-regulated if the temperature is not on an optimal state. So if you have either fever or hypothermia, acidosis will develop. RCT it is RCT, it is a randomized controlled trial that have shown that normothermia by a heating cover reduces wound infection and further complications. Even so, furthermore, there's a trauma death trial. It is composed by hypothermia, by acidosis, and coagulopathy. So that's why you see that they cover the patient with these silver sheets, and in some advanced trauma centers they have sheets that have they put just some sort of a vacuum that pushes between the sheet and the patient that pushes warm air. Have you seen it? You can see this in fancy hospitals or private hospitals. In the recovery room after surgery, they get the patients to an area and they cover them with a blanket, and between the blanket and the patient, they put some sort of a vacuum tube that pushes warm air, and the patient keeps warm. So we avoid acidosis by avoiding hypothermia. All right. Yes, randomized controlled trials. And okay, we have to stop the systemic inflammation by attending the main cause, the main injury, whether it's a hypovolemic shock due to trauma, or septic shock, or any other. We have to treat the main cause. We have to keep, especially in septic patients, these two are especially in septic patients. There have been plenty of studies that show that we have to keep the patient within normal glycemic ranges. I know that the catabolic phase makes every pathway to have a hyperglycemia on the bloodstream, but this eventually led to more complications and death. Therefore, in septic patients, we have to give them insulin if needed to keep the blood levels within normal range. And have you recalled that I told you that there's an acute reactant, which is the activated protein C? Well, there's a medication, this is very new, that is called Sigris. And it is an activated C protein that has been shown to reduce mortality in septic patients with multiple organ failure, or on a scale of Apache above 25. What does it do? Well, it is proven to be an I am so sorry, I have been kicked out again. I'm back again.
You were about to tell us what is the mechanism of action of Sigris. Why does it help?
Yes, this is a very interesting part. This medication is only to be used in septic patients that have multiple organ failure or have been evaluated by the severity index score, which is called Apache, above 25. And what does it do? It has anti-thrombotic properties because it inhibits factors 5 and factor 8 of the coagulation cascade. And it has a protection effect on the endothelium, making it, well, resolving the edema, and it prevents that extends any further. And it has some sort of anti-inflammatory properties in stimulation of angiogenesis, and promotes wound healing. But of course, if you block the coagulation factors, what would be your most dangerous side effect?
Bleeding.
Bleeding. That's right. That's bleeding, and they have reported some bleeding, especially on the gastrointestinal system, either stomach or intestine or colon. But we can live with that if your patient lives. This is the new thing.
And I have another question. Is
Yes.
activated C protein the same thing as proteína C reactiva or C reactive protein?
Sorry, can you say that?
Yes. So, is activated C protein, is it the same thing as proteína C reactiva or C reactive protein?
Yes, it's the same thing.
Okay.
It's the same thing.
Okay.
I have a question.
Yes.
It was the factor number 5 and 8 or 10 and 8?
Yes. 5 and 8.
Okay, thank you.
You're welcome. Well, so I guess that's it. And of course, during starvation, it happens what we just saw. The body start using lipids and start using proteins in order to keep glucose running. You may keep your patient in a fasting state or starving state at the most 10 days. Otherwise, you have to think a nutrition route for your patient. And well, that's it. That's it. I think that's it. For example, can you recall your solutions class? Watch this. If you give your patient on a fasting state mixed solutions or glucose solutions, you provide a bit of glucose, and by doing so, you're avoiding the skeletal muscle breakdown. That's why you see these kind of solutions, especially in surgery. Between the first day or 2 days that your patient has been starving or in a fasting state, that's the reason why you give a glucose solution or a mixed solution, because you're trying that your patient, of course, is entering a metabolic response to trauma. Therefore, is going to be in a catabolic state, no matter if your surgery went fine. If your surgery went fine and you didn't have any incidents nor complications, it doesn't matter. If you cut off a finger, you're going to have to go through the metabolic response to trauma. As little as it seems, then maybe your F phase will last about 10 minutes and your catabolic phase will last for about 4 hours, and then you will be in your recovery state. Is this clear? It doesn't matter how little the injury was. You're going to fall into the metabolic response to trauma. Maybe you're going to fall in a bit, but afterwards you're going to be in no matter what. Any questions? Of course, you have to avoid, as long as you can, that your patient stays immobile. You have to promote that he walks as fast as you can in order to prevent muscle wasting. And, well, that's it. That's pretty much it. Have you had any questions?
Yes.
I have a question. So, what's the stimuli that produces inhibition of hunger? You said that it was because the body was eating itself, but for me that doesn't make any sense. If you need if your body needs energy, why wouldn't it be asking for it with something, like with an action? I don't know.
All right. If your question is addressing hunger by itself, let's remember, first and foremost, we have a type of situation. If a person has been involved in an accident, that person won't be able to eat. Number one. Number two, you avoid these because you have to make sure that your patient has a digestive system complete enough to function. And you cannot say this if your patient has been involved in a major trauma. And third, you already know that your patient is going to fall into hypoglycemic state. So your first need won't be feeding him, because he's going to fall into that state whether you do something or not. As a matter of fact, that state is going to try to stop the injury itself. So that's why we don't need to worry about feeding our patients within the first day or 2 or 3 days, because we already know that phase is gonna move on. Perhaps we may start some mixed solutions in order to keep the glycemic state. But if we're talking about septic patients, especially septic patients, it is forbidden to keep them into hyperglycemic states, because studies have shown that in septic patients, keep them with hyperglycemic values will eventually complicate them and increase mortality in time. Any other questions? Hello, anybody there? I'm out again?
No. Here we are. Thank you.
Sorry, I thought I was out. So, it's very easy, right? It's not that complicated.
Yes.
Okay, your middle term evaluation will be available until Sunday at 23:30 p.m. And your next assignment will be an article about surgical site infections. It is a short article, so don't panic. I will try to upload it tomorrow, and I think that's it.
When is the article?
Questions?
When do we need to hand in so we just need to read it, or do we need to do an activity?
No, you need to read it. No, you're not going to do any activities. I'm going to upload like tests, like little exams. So you read it, and I'm going to upload another exam about surgical site infections, which will be available until the next week on Sunday too.
So for this Sunday is the quiz of the article, right?
No, for the next one.
Ah, okay. Thank you. Thank you.
For this Sunday, it is your due limit time for your middle term exam.
Do we have class on Sunday?
No. Sorry, no, I won't be here. I think, is this time suit you better?
No.
All right. Okay, we'll switch it back again until next Wednesday at 9:30. Is that fine for you?
Yes, thank you very much. That's better.
I think it's better for me too because the internet over here actually sucks. So I'm kicked back again. So it'll be better if we all see each other at Wednesday 9:30.
Okay.
All right. Well, thank you for being here. I'll see you on Wednesday.
Thank you. Bye. Have a nice weekend.
Bye-bye.
Thank you.
Bye. You too. Thank you.